Welcome to the third lecture in our series for the Aerospace Medicine curriculum. Today, we will be covering decompression illness, barotrauma, and decompression sickness. My name is Craig Kutz. I'm a graduate of the University of Texas Medical Branch Aerospace Medicine Residency Class of 2024, and I am board certified in emergency medicine and undersea hyperbaric medicine. This presentation uses material from the original mini-series curriculum and expands upon it in the 2024 update. Our residency and associated projects are funded in part by NASA. As a disclaimer, the content in these presentations serves as basic introduction to aerospace medicine concepts for students. It is not a substitute for formal ACGME accredited aerospace medicine training or aerospace medicine work experience, and shall not be used as such in medical practice or decision making. This material, including text images and multimedia, is protected by copyright and other intellectual property laws. The content is provided for informational purposes only and may not be copied, reproduced, distributed, transmitted, displayed, modified, or otherwise used in whole or in part without the express prior written permission of the University of Texas Medical Branch at Galveston. Today, we will focus on these objectives. You may pause your video now to read them. The last lecture in our series discussed the changes in pressure associated with altitude. You will recall that we learned that with higher altitudes, the pressure decreases. The opposite is true at depth. The deeper you descend, the higher the pressure. Our primary focus will be on changes in pressure and physiologic effects when diving, although we will relate them to aerospace environment. As you can tell by this graph, pressure increases at a greater rate underwater than it does when changing altitude. Notice that with depth, the increase in pressure is linear, whereas with altitude, the decrease is nonlinear, as we learned in the last lecture. In order to understand some of the concepts moving forward, it's important to differentiate the different types of pressures. The column of water above a diver causes a linear increase in 1 atmosphere every 33 feet of seawater or 10 meters of seawater. This is caused by the hydrostatic pressure of water, or in other words, all of the water above a diver. Contrary, at sea level, the entire column of air in the above atmosphere is equal to 1 atmosphere pressure. Now, let's take a look at gauge pressure. When a diver looks at their pressure at 10 meters or 33 feet underwater, the gauge tells them it is 1 atmosphere. If they return to the surface, this gauge pressure would read 0. Gauge pressure does not take the air column above into consideration and is often stated in atmospheres or ATM. When the air column above a diver is added, this is called the absolute pressure. Quite simply, this is the gauge pressure plus 1 atmosphere of air column. Absolute pressure is referred to as ATA, or atmospheres absolute. Most diving in hyperbaric medicine uses ATA, atmosphere absolute, for convention. So, our diver at 10 meters or 33 feet depth is at a gauge pressure of 1 atmosphere ATM, but is experiencing 2 atmospheres absolute, or 2 ATA of pressure. As you descend every 10 meters or 33 feet, an additional 1 atmosphere is stacked on top of the water above you. Thus, in this example, when our diver is at 20 meters or 66 feet of seawater, this is equivalent to 3 ATA atmospheres absolute. However, the diver's gauge pressure still would only read 2 ATM atmospheres. Listed here on this slide are the pressure equivalent units. Important ones to know and recognize are that 1 atmosphere is equal to 14.7 pounds per square inch, or psi, and 760 millimeters of mercury. With some simple math, we can then determine that 1 foot of seawater is equal to 0.445 psi. These apply to both altitude and diving. Now, let's take a look at one of the fundamental physics laws to understand when discussing pressure-related illnesses, or barotrauma, called Boyle's law. This is one of the ideal gas laws, stating that at a constant temperature, the volume of gas is inversely proportional to its pressure. Boyle's law is P1 times V1 is equal to P2 times V2. In other words, as pressure goes up, volume will go down, and vice versa. Let's take a fun look at Boyle's law in action. In this video, you can see a styrofoam bust that was placed in a hyperbaric chamber. As the chamber dives, the pressure increases and the volume of styrofoam, which is mostly gas, of course, decreases. With the Boyle's law formula, an inverse relationship curve can be generated as shown on the left. Notice that for the same change in pressure at low pressures, you get a substantially greater increase in volume due to this inverse relationship. The table shows the actual relative values. When you descend, the pressure increases, and the relative volume of trapped air will decrease in a predictable manner. Notice again that the percent change in volume at shallower depths is greater than the percent change in volume much deeper due to this inverse relationship. We will discuss why this is important later on in this talk, but this is a key concept to understand. Why does this matter in medicine? Let's take a look at a visual representation. If a balloon at sea level is taken to 33 feet or 10 meters underwater, the volume will decrease by half. If this same balloon were taken from the surface down to 66 feet or 20 meters, the volume would decrease to 33% of its original volume at sea level. This doesn't seem bad at first, but let's consider the opposite when you ascend. So let's replace the balloons with someone's lungs. If they decide to hold their breath at 66 feet with a made up, let's say, arbitrary value of 1 liter of air, by the time they get to the surface, if no air escapes their lungs, the volume increases to 3 liters based solely on Boyle's law. I understand in this example, the average lung capacity of an adult can be 6 liters, but this example is highlighting that by holding your breath and changing pressure, the overall volume of a fixed gas can expand volume drastically and lead to complications as a result. The golden rule when diving is never hold your breath, and this is due to Boyle's law. In particular, at shallow depths because the percent change in volume is much greater below 33 feet or 10 meters of seawater. This is a very critical concept to understand pressure-related illnesses. The next important fundamental physics law to understand is Henry's law. This is the law that underlies the illness called decompression sickness, which we will discuss shortly. Henry's law states that the amount of gas in a liquid or tissue is directly proportional to the partial pressure of that gas over the solution. So, the higher the pressure of the gas over the solution of tissue, the more gas will dissolve in the solution or tissue. And the lower the pressure of gas over the solution, the less gas will dissolve. A practical example of this is with a 2-liter bottle of soda. As we all know, soda is carbonated under pressure. The bottle on the left has the cap on, so the pressure of the gas over the solution is high. Because of this, the carbon dioxide is all dissolved in the soda. If you were to inspect this soda in a closed 2-liter bottle, you don't see any bubbles, because the gas is dissolved in the liquid proportional to the pressure over the liquid. But what would happen if we opened the bottle? The bottle on the right has the cap off. What did taking the cap off of the bottle do to the pressure over the soda? It decreased the pressure. When the pressure over the soda decreases, then less carbon dioxide will dissolve in the solution. So, carbon dioxide comes out of solution in the form of bubbles and escapes. So, the next time you open a can or bottle of soda, hear that familiar noise, you will know this is Henry's law in action. At this point, you're probably thinking, wait, what is with all this physics? I expected a medical lecture. Well, these ideal gas laws are crucial to understand the pathophysiology of pressure-related illnesses, such as decompression sickness and air-gas embolism. But this is a good point to make a clear and oftentimes confusing distinction. Decompression sickness and air-gas embolism are not the same disease. Although they both involve changes in pressure and end in bubbles, the mechanism and physics behind them are each very, very different. Henry's law, or dissolved inert gases in a solution based on pressure, is the underlying cause of decompression sickness. Boyle's law, or gas expansion barotrauma related to pressure, is the underlying cause of air-gas embolism. Over the last couple decades, the term decompression illness has been used to describe both of these pathologies. This is mainly, as you will see, due to overlap in signs, symptoms, and treatments. The distinction between the two may not be as clinically important when caring for a patient. However, now that you understand the physics, you can appreciate that they actually are two distinct clinical pathologies. Decompression sickness, or DCS, can be classified into two subgroups, type 1 and type 2 DCS. Type 1 is less serious and it can involve the joints, skin, or lymph nodes. Type 2 is much more serious and can involve neurological, cardiac, or pulmonary symptoms. So let's take a little deeper look into decompression sickness. Remember the physics concepts that we reviewed? This is where they come into play. Decompression sickness is a direct result of Henry's law. So let's take a look at an example of a scuba diver. Just like our bottle of soda, gases dissolve in proportion to pressure. While breathing compressed air at depth, the higher pressure causes more inert nitrogen to enter the lungs. This in turn creates a higher partial pressure of nitrogen in the blood and eventually the more nitrogen that dissolves in tissues. So, when humans dive or experience hyperbaric pressure, more nitrogen dissolves in the tissues. If we graph the pressure versus time, you can see that when the pressure at depth goes up, the partial pressure of nitrogen also increases due to Henry's law. If given enough time, the total amount of dissolved nitrogen in the tissues eventually increases as well. Note, this graph is not exactly to scale, but it's a really good way to highlight some of our general concepts. The unique part about the human body is that each tissue can dissolve nitrogen at various rates based on specific pressures. So the generic curve pictured here may be different for various locations within the body. For instance, the joints and cartilage may dissolve nitrogen in a very different rate than the muscles. When our hypothetical diver decides to ascend to the surface, what happens to the dissolved nitrogen in the tissues? When the pressure decreases from ascending, the nitrogen partial pressure decreases as well, as you can see by the green line. If slow enough, eventually the body gets rid of any excess nitrogen from the tissues through the blood and breathe out during exhalation without any complications, as shown by the red line. Again, this is due to ascending slowly to the surface, and the dissolved nitrogen in the tissues can be removed safely from the body. However, let's just say our diver ascended rapidly and did not give enough time for the partial pressure of nitrogen to equilibrate. Or, in the case of aviation, for example, if the pressure difference changes rapidly. This can lead to tissue supersaturation of dissolved nitrogen. If you remember back to earlier, decreasing that pressure rapidly in a supersaturated solution can create bubbles of gas coming out of solution. Or in other words, Henry's law states that just like our soda bottle, bubbles come out of solution when the pressure rapidly decreases. This is the basis of decompression sickness and the origin of DCS bubbles. When bubbles form in the tissues, they are picked up and carried away in the venous vasculature. The image on the left was an experimental model that shows actual nitrogen bubbles forming in the bloodstream after a rapid decompression. Bubbles removed by the venous system enter the right heart circulation and eventually go to the lungs. Our lungs act like a big filter sieve and remove the bubbles without issues. In most divers, even at a safe ascent rate and under normal circumstances, bubbles actually can form. Yep, that's right. Bubbles can form in most divers under normal, safe circumstances. Important to realize is that this is not decompression sickness, as healthy, asymptomatic divers can create bubbles naturally. Normal bubbles on the venous side, called venous gas embolisms or VGE, can be seen by echocardiogram ultrasound or heard by Doppler. If you were to do an echocardiogram on a scuba diver after they ascend from diving, you may be able to visualize normal, non-pathological bubbles in the right heart system, as seen in this image circled in the orange. is not familiar with the orientation of cardiac ultrasounds, I flipped the image to match the graphical one on the right into a less conventional view and labeled the following structures: right atrium, left ventricle, and right ventricle. You can see that the right atrium and right ventricle show tiny hyperechoic or white dots. These are bubbles. Notice that the left side of the heart does not appear to have any bubbles. This is because the lungs filtered out the bubbles before they could reach the arterial system. So how does normal bubbles on the right side become pathological bubbles that cause decompression sickness? This echocardiogram video shows bubbles moving through the right side of the heart. If you look ever so subtly, you can see a few bubbles show up on the left side. Somewhere along the circulation, a shunt from the right side to the left side must have taken place. This echocardiogram is a more extreme case with large bubble burden on the left-sided circulation. This patient in particular has what is called a patent foramen ovale, or PFO. A PFO is a congenital hole between the right and left atria of the heart, resulting in blood bypassing the lungs with a right to left shunt. PFO is surprisingly common in the general population, with a prevalence of as high as 30%. This is one example of shunting that can take place, causing bubbles to enter the left side of the heart. Bubbles that are normally filtered by the lungs are bypassed through the PFO in the heart to the arterial blood supply. Then, they can travel to the brain, spinal cord, or other tissues to cause disease. A PFO is not the only cause of shunting that can lead to arterial bubbles. Another, for example, are arterial venous malformations, or AVMs. However, the main objective of this slide is to highlight the underlying pathophysiology of how serious forms of decompression sickness are caused. The pathology these bubbles cause is a complex cascade involving vascular damage, tissue ischemia, inflammation, and reperfusion injury. Unfortunately, for serious cases of decompression sickness, this cascade can be self-propagating and lead to more damage downstream of the initial bubble load. This self-propagating cascade is also why, as you will see later, symptoms of DCS can present delayed. As a quick reminder, there are two types of DCS, type 1 and type 2. Type 1 includes musculoskeletal, cutaneous, or extreme fatigue or constitutional. Type 2 is often more serious and includes neurologic DCS such as spinal or cerebral, cardiopulmonary, and vestibular or inner ear DCS. By far, the most common organ system affected is musculoskeletal or joints, with nearly 2/3 of cases presenting with symptoms localized to the musculoskeletal system. Constitutional is the second most common presenting symptom, and this includes extreme fatigue or described as, quote, feeling off. For the more serious causes, such as spinal cord DCS, motor weakness and paresthesias are common. Although urinary incontinence is often seen as a common symptom for critical spinal stenosis, it is not traditionally seen very commonly with spinal DCS. Cardiopulmonary is thankfully very rare, but has a high fatality rate. Why does DCS affect different tissues? Have you ever wondered why DCS most commonly presents as joint pain? If you remember back to the pressure and time graph from earlier, you may remember that different tissues can get rid of dissolved nitrogen at different rates. Although outside of the scope of this lecture series, just know that there are fast and slow tissue compartments, with the musculoskeletal being a slower tissue and thus prone to supersaturation and bubble formation. These graphs show that slower tissues can reach tissue supersaturation more easily and are thus more prone to bubbling. Let's focus on the clinical syndromes in type 1 DCS first. Musculoskeletal involvement is what is colloquially known as the bends. Symptoms include a deep aching, throbbing pain in the joints that is not very well localized by patients. It is often non-tender to palpation, and movement does not aggravate the pain. These can be mild to severe, but if left untreated, can lead to a chronic issue called dysbaric osteonecrosis. The skin bends is a spectrum from just pruritus or itchiness to actual skin changes, with the most severe involvement being a phenomenon called cutis marmorata. It is a cyanotic patch with mottling. Cutis marmorata is an ominous finding, as there is an association with progression to severe type 2 neurologic DCS. This is a photo of Cutis marmorata. You can appreciate the marbling of skin in this photo on this patient's thigh and upper arm. Since we are discussing type 2, let's move on to this more severe form of DCS. DCS of the nervous system can affect the spinal cord, the brain, or both. When the spinal cord is involved, exam findings include altered sensation, paresthesias, and can progress to paresis. The high-resolution MRI image on the left is a bovine model of DCS after rapid decompression, showing bubbles forming in the spinal cord. Cerebral DCS has a broader presentation, including visual changes, headache, motor and sensory deficits, confusion or personality changes, gait disturbances, or even seizures. Bubbles pass through cerebral vasculature, and the resultant ischemia reperfusion damages endothelium. If either of these is left untreated, it can lead to long-term disabling sequelae. Cardiopulmonary DCS is the next form of type 2 and has been referred to as the chokes. The chokes is a consequence of massive venous bubbling. These bubbles traverse the lungs and overwhelm the filtering ability, resulting in endothelial damage in the pulmonary vasculature, capillary leakage, and pulmonary edema. It often presents with dyspnea, cough, and retrosternal pain. Large bubble burdens can cause vapor lock within the cardiovascular system, leading to cardiogenic shock and hemodynamic instability. The chest X-ray shown is a case of cardiopulmonary DCS. The yellow outline shows the heart. Notice that the heart ventricles are visualized on this X-ray, a finding that's not typically seen in a healthy chest X-ray. This is due to the large amounts of air located within the heart itself, thus making it appear more closely related to lung parenchyma in this X-ray. This form of DCS has a high fatality rate. The last form of DCS we will discuss in this lecture is vestibular DCS, or inner ear DCS, colloquially referred to as the staggers. Inner ear DCS is caused by bubbles in the endolymph of the inner ear, leading to vertigo, tinnitus, and decreased hearing. Resulting nausea is common due to vertigo and often presents with an unsteady gait as well. It is very important to distinguish that this is not caused by ear barotrauma or ruptured tympanic membrane or round window. Barotrauma can present very similar to inner ear DCS, but the treatment is vastly different, and thus it is important to differentiate. So how do you prevent DCS? The best way is to follow dive tables, such as those seen on the right side of the slide, or dive computers. These are meticulously designed through experimental trials to optimize a diver's time diving, while limiting their risk of decompression sickness. In general, dive tables give a rough estimate of how long and how deep a diver can go before they are at risk of DCS. A good rule of thumb for clinicians unfamiliar with dive tables is that dives that exceed the 120 rule may be at risk for DCS. Simply put, for a single dive, adding the maximum depth and time underwater should not exceed 120, roughly. So this is a guideline. It is not an absolute. Other good practices include slow ascents from depth and not flying after diving or hyperbaric operations. Other key pearls for decompression sickness. In general, dives below 20 feet of seawater or 0.6 atmosphere pressure is unlikely to be decompression sickness. They could still be at risk of an air gas embolism, which we will cover shortly, but at these depths, the pressure is not great enough to dissolve enough nitrogen into tissues to create the pathophysiology of DCS. Also, nearly 99% of symptoms for DCS occur within 24 hours after ascending from a dive, with the most severe cases, like type 2 DCS, occurring within the first 1 to 3 hours. Therefore, if the onset of symptoms occurs more than 24 hours after the person finishes a dive, alternative causes for that person's symptoms should be considered. So to summarize these pearls, The first one is the 120 guide, which states that the time underwater and maximum depth should not exceed 120 roughly. Dives that exceed this are considered a risky profile for DCS. The second is the 24 for 24, or symptom onset for DCS occurs within 24 hours after surfacing, and a depth of at least 24 feet of seawater is required to be at risk for DCS. Now, this is a value actually more consistent with 20 feet of seawater, like I said in the last slide, but 24 for 24 is a good estimate for sake of memorization to those new to diving medicine. As in medicine, there are always exceptions and should be a reminder that these are just guidelines and not absolute values. So what about aviation and space medicine? Why are we talking about divers so much in an aerospace medicine lecture series? Up to now, we've been discussing hyperbaric decompression sickness. In other words, a diver at depth experiences higher pressures, and ascending to the surface, the pressure is significantly less. Let's consider the other side of the coin, aviation or hypobaric decompression sickness. In that same vein, a pilot on the ground is at higher pressure than when they fly in an aircraft at altitude. Although most aircraft cabins are pressurized, if that pressure were to suddenly drop due to rapid decompression, the differential pressure between the two could mimic the change in pressure we've been discussing with diving. This graph is reported by the U.S. Air Force Handbook of Aerospace and Operational Physiology, showing the incidence of aviation or hypobaric DCS. According to this research, only 1% of DCS cases occurred when the pressure changes occurred from at least a flight altitude of 18,000 feet. If you remember to our last lecture in this series about altitude, this is equivalent to 0.5 atmospheres or half atmosphere. This reflects a 2-to-1 ratio of pressure change, similar to the pressure change seen in a scuba diver from 33 feet seawater to the surface. This topic is greatly oversimplified for the scope of this lecture series, but highlights that at a certain altitude, with a big enough change in pressure, DCS can occur in pilots. Similarly, pressure changes occur in space operations as well, where vehicle or habitat environments are pressurized to higher levels than extravehicular activity spacesuits, and thus pose the risk of decompression sickness. At higher pressures, more gas is dissolved in the tissues. With hyperbaric diving, this occurs at depth. With hypobaric or altitude, this occurs when you are at ground level before the flight. To generalize, DCS onset occurs in the lower pressure environments, highlighted in the yellow. So for diving, this means at the surface. For aviation, this would mean in the air. And for space operations, this would mean in the lower pressurized suit or vehicle. Knowing what we have learned, it is worth comparing operational consequences of decompression sickness for each of these. With hyperbaric operations, hyper meaning more, so more pressure, decompression sickness occurs at the end of an operation when the participant has come back to the surface, such as scuba diving. This is convenient because they are done with their operations at depth. With hypobaric operations, hypo meaning less, so less pressure, DCS occurs during the operation. So, you have an aviator who is at altitude in a multi-million-dollar, extremely complex aircraft experiencing symptoms and expect them to fly themselves to safety. You can appreciate that this could have serious consequences. The good thing about DCS at altitude is that descending and landing has already initiated your treatment. In general, hyperbaric or diving DCS is more severe and type 1 localizes more to the shoulders, whereas hypobaric or altitude DCS is less severe, primarily presents in the musculoskeletal system, and localizes to the lower extremities. Since symptoms can occur during operations for aviation DCS, it's important to prevent the development. The concept of pre-breathing is a method aviators and astronauts use to mitigate this risk of decompression sickness. Basically, aviators breathe 100% oxygen for a certain amount of time that gets rid or washes washes out all the nitrogen in their tissues. Oxygen bubbles are tolerated much better by humans, and thus the risk of DCS is negligible. With all the nitrogen washed out from the tissues, you effectively lower the chances of developing any nitrogen bubbles and DCS. Now, let's shift gears slightly and focus on arterial gas embolisms, or AGE. AGE is one of the diagnoses encompassed in decompression illness, but as is illustrated by the flowchart here, remember, it is a very distinct pathology from decompression sickness. To review, AGE is governed by Boyle's law, or P1V1 equals P2V2. Remember that at a shallower depths, due to the inverse relationship of pressure and volume, a greater change in volume occurs with small changes in pressure. When the pressure decreases, the volume rapidly expands, such as when a diver holds their breath from depth and ascends to the surface. In the lungs, this can lead to ruptured alveoli and lung tissue, creating air leaks. The ruptured alveoli and air leaks create bubbles in the arterial system and can act like a stroke, forming occlusive bubbles in tissues like the brain. This transition is a lot faster than the one we discussed about DCS, since no shunting is required. Therefore, the onset of symptoms can occur much faster, often within the first 10 to 15 minutes of ascending. AGE can occur in many operational situations, including breath hold diving or rapid changes in pressure. Symptoms often mimic strokes, with neurologic deficits or seizures common. Sudden loss of consciousness can also occur. A large AGE can also cause vapor lock in the cardiovascular system and lead to sudden cardiac death. If the bubbles escape into the space around the lungs and the thorax, it causes a pneumothorax, sometimes referred to as a collapsed lung. If the bubbles escape into the mediastinal space, it causes pneumomediastinum. And finally, if the bubbles escape under the skin, it causes subcutaneous emphysema. This is typically seen near the clavicle, and the air can be palpated. It oftentimes feels like crunchy Rice Krispies. Now we are going to discuss ebullism. Although ebullism is not one of the diagnoses included in decompression illness, it intuitively makes sense to discuss it here because the concepts are very similar. We discussed ebullism briefly in the last lecture in this series, in particular in relation to Armstrong's line at 63,000 feet of altitude. Remember that Armstrong's line is the altitude at which the ambient pressure reaches the vapor pressure of body fluids, or 47 millimeters of mercury, allowing ebullism to occur. When this occurs, fluids in the body essentially boil. As you can see from this slide, ebullism essentially results in multiple organ failure and is fatal unless it is immediately corrected and treated by restoring pressurization. Treatment is not futile, as there have been surviving cases reported. So let's finish up our talk by discussing how we treat DCS and AGE. The definitive treatment for both DCS and AGE is hyperbaric oxygen therapy. You can see pictures to the right of a hyperbaric chamber. The definition of hyperbaric oxygen therapy is providing 100% oxygen to a minimum of 1.6 ATA of pressure. Don't be confused by gamma altitude bags we discussed in the prior lecture, as they can only attain a maximum of about 1.2 ATA and thus are not considered hyperbaric oxygen therapy. The most common treatments given are the U.S. Navy Treatment Table 6, or TT6, Treatment Table 6, and 6 alpha, or 6A. You can see the pressures listed on the slide. Hyperbaric oxygen therapy treats DCS and AGE in multiple ways, most notably by increasing the pressure to crush the bubbles, meaning it makes them smaller. It also has a large role in reduction of the inflammatory cascade and ischemia discussed earlier, but this is outside the scope of this lecture. It also, through Henry's law, keeps the bubbles dissolved in the blood instead of having them come out into the tissues as bubbles. If the gas is dissolved in the blood, it can be transported back to the lungs and eliminated from the body through respiration. To aid in this respiratory washout of nitrogen, patients are placed on oxygen. Note that supportive care is also given to patients in hyperbaric treatments, as necessary depending on their presenting symptoms. This is an example of a treatment table used for hyperbaric oxygen therapy. The details of treatments are beyond the scope of this lecture, but this is here to illustrate that the treatment involves adding pressure and breathing oxygen. Also understand that a treatment can take anywhere from 5 to 10 hours. The dark gray is breathing oxygen, and the white represent breaks, breathing air. The air breaks are designed to avoid oxygen toxicity seizures. Now let's take some time for a knowledge check. Case A. A newly certified scuba diver finishes their recreational dive and 5 minutes after ascent loses consciousness and starts having a seizure. He dove to 45 feet of seawater for 60 minutes. His dive buddy mentioned that it appeared he was having trouble with neutral buoyancy during his dive. What is the most likely diagnosis and most definitive care for this patient? Pause the video now to give you a chance to read the options A through F. The answer is B, air gas embolism and hyperbaric oxygen therapy. The diver had loss of consciousness within 5 minutes of ascending, which is in line with the timeline for AGE. In addition, the question talks about trouble with neutral buoyancy, often a cause of inexperienced divers ascending too quickly or holding their breath, one of the primary reasons for developing an AGE. Hyperbaric oxygen therapy is the only definitive treatment for AGE. Although a non-rebreather at 15 liters of oxygen would initially help and should be started as soon as possible, the definitive care is hyperbarics. Answer F is not absolutely correct because remember, decompression illness encompasses DCS as well as AGE, and this diver most likely suffered from an AGE, not DCS. A dive to 20 feet for 40 minutes likely isn't provocative enough to place the diver at risk for DCS. Question 2. What gas law explains the pathophysiology from the previous patient in case A? Boyle's, Henry's, Charles, Bernoulli's, or Dalton's? This should be clear after discussing that the most likely cause was an AGE, and the answer is Boyle's law. Remember, Boyle's law is the inverse relationship between pressure and volume. When the diver held his breath and surfaced, the volume in their lungs likely expanded to cause overexpansion and barotrauma. Henry's law is the basis behind decompression sickness. Charles' law is based on constant pressure and the relationship between temperature and volume. Bernoulli's principle we discussed in the previous lecture and is involved with the mechanisms of aviation flight. Dalton's law states that in a mixture of non-reacting gases, the total pressure exerted is equal to the sum of partial pressures of the individual gases. Let's look at case B. A U-2 pilot flying in a pressurized suit at 60,000 feet above sea level starts to experience pain in his knee and notices a tingling sensation going down his right arm. He cannot reproduce the pain in his knee by moving it. He also notices that he is having difficulty concentrating on his navigation calculations. He is diagnosed with type 2 DCS by the flight surgeon. Which of the following are true concerning aviation or hypobaric decompression sickness? Pause the video and take time to read each possible answer. The correct answer is D. Appropriate oxygen pre-breathing could have mitigated this event. Remember, oxygen pre-breathing is a form of nitrogen washout and reduces the risk of decompression sickness. For the other wrong answers, just remember aviation decompression sickness is often less severe than hyperbaric diving DCS and usually localizes to the lower extremities more frequently. Descent in aviation decompression sickness actually works as a form of treatment due to the increased pressure. And finally, hyperbaric oxygen therapy should be initiated as soon as possible and not delayed. Delaying definitive treatment can lead to propagation of the DCS inflammatory cascade and more downstream complications. This concludes this lecture. References are listed here and were listed on individual slides. We'd also like to give special thanks to Dr. Amy Krakis, the UTMB Associate Program Director and UTMB RAM graduate class of 2020, who created the original version of the UTMB Aerospace Medicine Seminar Series. And special thanks to Ms. Heather Medley for her tireless work in reformatting and updating the seminar series as part of the 2024 revisions. Also, special thank you to Dr. Natasha Cho, core faculty for the UTMB Aerospace Medicine Residency, for her guidance and leadership in this lecture series. And once again, thank you for listening. My name is Craig Kutz. I'm a UTMB Aerospace Medicine alumni from class of 2024. Thank you for watching this presentation. We hope that you enjoyed it. If you have any questions, please don't hesitate to contact us at the email listed here. Please stay tuned for our next lecture.